So today we have Dr. Jessica Otte and Dr. James McCormack. James is a longtime friend of the TI and a colleague. He's a professor at the University of British Columbia, Faculty of Pharmaceutical Sciences. He's also leading the BS Medicine educational offerings. He's been teaching people about evidence for the last 30 years and has done over 500 seminars on drug therapy. He's funny, he's bright, he's engaging, and this particular publication in the BMJ, which you'll be speaking about, is, I think, fantastic, and I'm sure you'll all agree. Dr. Jessica Otte is a family physician from Nanaimo, British Columbia, and she's a very gifted educator, very wonderful clinician, and has been working with the TI for the last couple of years, and she'll be joining James in a conversation about the BMJ publication. So without further ado, I'll pass it on to James and Jessica, and remember to post your questions and comments in the chat.
Thanks so much. I'm actually going to go downhill from there on that introduction. That was very kind of you. So thanks for inviting us to come and talk to you about some of the issues around medical measurements. And it's an area that I got into a few years ago because I was asked to do a talk for a group of lab people, and they said, I said, what do you want me to talk about? And they said, anything. And I said, well, can I talk about some of the problems and about measurements and all that sort of stuff? And that's where it all came from. And so just a quick conflicts of interest. My entire salary comes through the UBC Faculty of Pharmaceutical Sciences. I do some legal and education work sometimes. I've received no honorarium or research money from the drug industry in the last 30 or so years. And but we do make some money on a podcast that we put together. Most of the podcasts are free, but it's there is a premium podcast subscription model. And if you're interested, we've now been doing it for 12 years, and we've got 460 episodes. And it's been one of the great educational experiences of my career to do that. And it's a lot of fun. So check it out if you get a chance. BS Medicine Podcast. So it's BS without the BS.
And this is my conflicts of interest. So I'm a family doctor in Nanaimo, and I do a lot of care of the elderly and inpatient care. I try to lab tests where I don't want to know the results, but I'm hoping that I can help provide a bit of clinical perspective on that today. I don't have any industry ties, but I get various salaries part-time through the Therapeutics Initiative, some through the Health Authority through the usual MSP billing, and honoraria for committee work, mostly around high-value care and using drugs and technologies in the way that best reflects the patient's goals and wishes and the best available evidence.
So what we're going to do is I'm going to spend some time sort of going over the background of some of the concepts, and then Jessica and I are going to go through a variety of cases to sort of help you think about how do you take that information and put it into context. So all of this came about from an article that we published in the BMJ just about 10 months or so ago. And it was with the help of Dan Holmes, who runs the lab at St. Paul's Hospital. We put together a discussion piece, if you will, on the imprecision of medical measurements. So if you're interested at all in this, please check out that article. And what was really cool is that the BMJ made an interactive tool that you can go and use. And what it allows you to do is you can take a lab value, and we've got the top, probably 30 or 40 lab values that you typically would use. And you can put the lab values in to there, and it'll show you all of the variation that's associated with each one of them. And it'll also, if you have two results, you can actually make an assessment about whether or not it's likely to have changed, because there's some nuances around that. So check that out, and we'll talk about that at the end as well. So lab values are really important. There's a lot of things that we make a diagnosis on the basis of lab stuff. For those of you going, I can't see this screen, you're not supposed to be able to read all this. It's just an example of some of the things that are there. And as you all know, there's a number of rules in the last number of years that now patients get direct access to lab results. And unfortunately, it's almost exactly the same report that goes to us. And I know from experience that it's tricky to sort of figure out those reports. And I would suggest, based on what we're going to be showing you guys, is that many healthcare providers don't appreciate the key nuances of lab tests. I think we get pretty good at it, but there's a lot of nuances. So I have sort of a thesis, if you will, and it's that I think as a profession in healthcare, we try to knowingly sell precision. And I think, I don't think we can do it all that well. I think we can provide educated estimates and stuff, but I think we need to be much more open about the imprecision of medicine, if you will. And I think so. It's really important. And we actually can't, sadly, be precise about the imprecision. And we'll talk about that as we go through this. Now, I'm sure some of you recognize this movie, and I'm sure you won't be paying any attention at all as it's sort of playing through. I don't know, is the video moving on? Can you guys? Yeah. So there is problems when we give the illusion or fake precision. We give the belief that that these thresholds are very black and white, and that's not a good belief when you fake these sorts of things. And then we also give a belief that, that when the numbers change, that those changes are actually real. And so it's really important that we be careful to do that. And I know, again, none of you are paying attention, you're just watching the video, but we need to be aware that these sort of false beliefs, and these beliefs can add inappropriate feelings of fear, happiness, frustration, confusion, all over the board. So what I want to do is give you some enough guidance as how to think that through. So it's really important to look at the imprecision. And I know, Jessica, when I'm you know, before I looked at all this, I always thought that it was all just lab imprecision. I'm sure that's kind of what you somewhat thought.
Yeah, I think, and there's a certain arbitrariness of how we think about it too. Like if my patient's hemoglobin is 71 today and 70 tomorrow, yeah, like the guidelines have these cutoffs at certain places, and I guess I never really understood where those numbers come from necessarily, and I might have assumed that some of it's interpretation, but if there was error, that it was going to be well, the lab took the sample from the wrong place, or it sat too long in transit, if there's going to be variation there, for sure.
Yeah, no, exactly. And that was sort of where I thought most of the imprecision came out. It was sort of lab error, but there's three sources of imprecision in lab tests: is lab error, analytic variation, and biologic variation. And this is going to sound sort of, there's a lot of science behind this, but I think it's important just to contextualize and understand what each one of these sort of mean. So fortunately, from an actual lab error perspective, now this is old data, this is like 13 years old, but really lab errors are now, because of how well we do these things, they're relatively unusual, certainly under 1%, where it's labeled wrong or it's taken inappropriately, it's wrong instruments being used and all that. So we're pretty good at that. And in fact, from a pharmacy perspective, we have more dispensing errors than when we see with lab errors. So lab errors are not a big deal. Can they occur? Absolutely, but they pale in comparison to some of the other errors. So what we want to do is trying to give you a landscape to think about this. So let's assume there are no lab errors. Let's say that the result is a real number, and so when we get the reference intervals, they're population-based reference intervals for most of these things, and they're based on evaluating healthy people and finding, if you are healthy, how many people fall outside that range and still are healthy. So we're not actually identifying disease, we're just looking at the overall range of what is typically seen in a otherwise healthy population. And then we have analytic variation, biologic variation, and reference change values, which was, again, a term I was not familiar with, but it's it's used a lot in the whole lab era. So the population-based reference intervals, this is the range where 90% of healthy people fall. So it doesn't, by definition, mean you're unhealthy, but obviously more unhealthy people will fall outside these ranges. So we're not going to spend really any time talking about specific reference intervals, because that's a whole other talk on itself. What we want to do is just talk about how comfortable are we, or confident can we be about the specific number. Because, and I don't think, Jessica, I don't think there's really any other reasons we do tests. I mean, we want to know, what are the results now, and have they changed from previous measurements? That's kind of what we're doing, right?
Yeah, I think we use a test to try to figure out, is something changing because of intervention, despite intervention, or will it trigger the need for intervention? And so that looking at a person's renal function over time, oh, they're getting into territory where I'm going to have to stop some drugs that are renally processed, or it's really that trend over time that that is helpful. Sometimes we want the immediate result. Is, black and white, is the troponin high or is it not?
Right.
But a lot of times it's a relative thing. Absolutely.
Yeah. And so those are two different things, and the way we deal with the variation in tests is different. And the way to think about it is, it's a sort of a simplistic form, but if you think about analytic variation, is that every measurement you make will be different. So in this image here, you can see this kid is trying to measure the height of probably his sibling. And you can envision that there is going to be a variety of errors if he does it this way. And you can just look and see, he can't see to the top of her head. The ruler is bent. He's a 4-year-old kid. I mean, all sorts of variations that can go on in that. So that's the analytic variation that we see. And so that's why every time he measures his sister, her height is different, but we know intuitively her height has not changed. But then there's the biologic variation, and that's the variation within the person who is being measured. And, in this case, it's not truly a biologic variation, but, she could be slouching a little bit. She could be sort of just trying to annoy her brother. She could be wearing shoes or not wearing shoes, all sorts of different things, or her height could be changing over time. So those are the things that we need to take into account. But it's that inherent biologic variability that is actually the key thing that we want you to understand at the end of this talk. And then there's a thing called a reference change values. And what a reference change value means is it takes the biologic and analytic variation, and it allows us to make a ballpark estimate of how big a change do you need to see so you can rule out that it was just a chance finding, because with every test there's variation. So this is just an image to show you the range. So when you get a precise number back from the lab, and sometimes to decimal points that are just ridiculous in their accuracy, but we use this reference change value for serial results. So we get one and then we get another one later. So we use that with serial results. And what we can do sort of fancy calculations of looking at the coefficients of variation. And basically all it is doing is taking the analytic plus the biologic variation, and there's always going to be a bell-shaped curve for that. So you got a specific result, but it's somewhere in that bell-shaped curve. And when you get two results, you get two bell-shaped curves. And what we try to do is, if the bell-shaped curves do not overlap, then we're pretty comfortable that these results are different. It doesn't mean that this is exact and this is exact, but it means that we think that the result is trying to change. So it's kind of a plus minus, if you will, of that. And so we can do that and mathematically calculate that. So it's the minimum difference between two consecutive results which needs to be exceeded to state that a statistically significant change has taken place. So the nice thing about it is that analytically speaking, we've come a long way in labs from the last 30 or 40 years, is that labs try to make sure that analytic variation is about 1/2 the average within subject biologic variation. So what that means is there's two different types of variation, analytic and biologic, but we can actually improve analytic variation by making the test better. And when we get that analytic variation to less than 1/2 of the average within subject biologic variation, the analytic variation it becomes of no value. It's the entire RCV is determined by the CVI, which is the biologic variation. So we are now at a point in most lab tests that the lab error is not an issue. The analytic is really quite well done. Not every test, but they're pretty good. And there's different analytic variation between tests for sure as far as percentages. So it's this biologic variation that's a problem. So that's what we need to sort of focus on as we go through. So when we see, and that calculator that I showed you that BMJ put together for us is calculating a reference change values. And it's going, can we rule out that the difference is due to chance? But just because we can rule it out doesn't mean that the magnitude of that difference is seen. So if you got a potassium of, at one time it passed potassium of 3, and then another time you measure it, it's 4, we can say that those two numbers are likely different, but we can't be all that sure that the actual magnitude of that difference is 1, because there's a variation around that as well. So there's a lot of variation, as you can see. So we can believe the two results are different, but we can't necessarily quantify that difference with any clear precision. some people say, well, what about if we did multiple measurements and so on? So if you do multiple measurements, this is an interesting publication that helped figure out if you do a whole bunch of more tests, like if you do 4 cholesterols ahead of time and average those out, and then do 4 afterwards, can you get rid of some of that variation? And you can. But I mean, Jessica, I don't know if you've ever done it. Have you ever done like 4, cholesterols in a row over a few days, and then average them out, and then given a drug, and then measure them 4 times afterwards another month? No one does that, right?
I don't think we'd be allowed to keep working if that's how we treated
No,
our
no,
patients.
exactly, yeah. But if you were to do 4 before and 4 after and average them, you can get rid of about half the variation. So that's what that 0.5 means. But no one ever does that. And so, and we're not actually suggesting that you do that, but it's one of the reasons, for instance, when we do multiple measurements of blood pressure, because we're trying to reduce the variation that we see, or the biologic variation. So lab error, not a big deal. Analytic variation, certainly an issue, but the big thing is biologic variation in this whole thing. So the enemy is us, and we actually cannot fix us. I mean, I know people try to fix us, but we really can't do that. So the problem is not fixable. Analytic variation is fixable, lab error is fixable, but biologic variation is only knowable. And we'll show you how that goes on. And so what we want to do is sort of go through a couple of cases and examples of how you can think about this. Jessica, is there anything else you want to add?
Yeah, just on the next slide, I think about this, or versus one after that. When I was working with James, just preparing what we would say to you, I was thinking that, yeah, there's a lot of issues with the different levels of variation, but there's also this bigger picture. So when you put a lot of faith on a number, or a feeling that a number is truly changed, there's a cascade of medical decision making that eventually goes into, like, what are you going to do differently for this patient? And I think keeping that in mind as we go forward and talk about these cases is really important, because with A1C, if a person is in hospital, they've just had a GI bleed, their hemoglobin A1C is going to be quite different than if they still had the same amount of blood volume. And there may be big things that happen there, and we might be tricked into changing our management based on seeing some sort of change that we believe is real, and forgetting about sort of the bigger picture and the context of the patients. It go on, because you need a good understanding of the errors that happen at the measurement level before you then start thinking about clinical application, about what you're going to do. And then the other part of this is, of course, like, what matters to the patient and how we interpret that. So a guideline might say target hemoglobin A1C to 7.5%. Where does that come from? If their A1C is increasing by this, use this drug because it decreases it by this percent. And there may be some flawed thinking in that. And then also the patient that you're caring for. So I have some patients whose A1Cs go up and down, 8 to 9 to 10. And whether I do anything about it or I worry about that change depends on that person's goals. If I'm trying to treat to some sort of targets, or if I'm trying to prevent symptoms of hyperglycemia, really depends on the person. So that's just the bigger picture, the context of looking at these numbers. So just an emphasis on not getting too hung up on, as you're understanding that variation, remembering there's also bigger layers of how we apply that information.
Yeah, no, that's great, because all of those things are really important when we make decisions. And it's interesting you brought up sort of guidelines. I mean, you and I have spent lots of time looking at guidelines, and they drive us crazy most of the time. I've looked at probably hundreds of guidelines, and almost never do they mention this issue. And it is actually a vital issue for a number of reasons as we go through this. So this is not something that is intuitive or used even in guidelines to deal with some of these issues. So if we look at an A1C as an example, so a single A1C result is really plus minus around 10%. So we have normal, a normal A1C, and I hate the term normal, but then we have pre-diabetes, and then we have diabetes. And so that's the A1C right now. So let's say you measured an A1C and it was 6.1. All you can really say is we think it's somewhere between 5.6 and 6.6. And you can see there's a big overlap there. It's more likely closer to 6.1 than 5.6, but it's still somewhere in that range. So you can confidently tell a person if they have an A1C of 6.1, you're either normal, you have prediabetes, or you have diabetes. That's as good as you can get with that sort of number. And it's why this is a fundamental problem with these sort of thresholds that people are using. Now, if you get an A1C of 9, that biologic variation is irrelevant. You know it's well above whatever threshold you might be using for treatment. And if it's normal, you know it's normal. It's those, when it's close to thresholds where we get very sort of obsessed with these numbers, that we need to be aware of that biologic variation. And then that 0.7% is just to remind me, that's the magnitude of the change that you see on average with a drug. Is that A1C changes somewhere between 0.7 to 1%. The RCV is, and that, remember what RCV is, that's how big a change you have to see to be comfortable that you can rule out just a chance change. That RCV is very, very similar to the change that you would see with a medication. So it is actually very difficult. And you can get misled quite easily when you remeasure to see if it's actually changing. So a lot of people, I know, talk to some people in the States who get sort of paid for quality care or get paid to get people to targets, is that as soon as they get a person to a certain target, they just stop measuring, because nothing good can come from doing more measurements, because there's too much variation in it sometimes. So that's the problem with it in sort of the glucose area, and even just as simple as seasonal variation. A1Cs have about, they go 0.2 up or 0.5% higher in the winter. And so there's all sorts of variation things that come into it. Anything you want to add to that, Jessica, or we can go on to sort of risk assessment?
I think we can go on to the risks.
Yeah. And then another thing, and this is outside that variation. So rather than sort of just doing you have diabetes or pre-diabetes or you're normal or whatever, there are a number of tools out there that are somewhat useful, kind of like our risk calculator that we use for cardiovascular disease. But this is something that I talk to people who have type 2 diabetes to show them these are the risks based on what happens to your A1C. And you can see there's no clear inflection point there. As glucose goes up, risk goes up. But so what I would try to do is show them why 6 versus 6.5% is not that much of a difference in risk, maybe 1% or 2%, over a number of years, over say 10 years. And so it's really important that we not only deal with that variation, but also what do we do with, rather than telling someone that they are diabetic or pre-diabetic, because, and I know you just, that's an emotional thing when you tell people that. It can, no one goes home and goes, guess what I got from the doctor today? Diabetes. So it's an important issue.
Yeah, I think
so.
We
Yeah,
put
go
a
ahead.
lot of emphasis on those those lines. There's a line at which you are and which you aren't, and people get stuck on medications for a long time because of their belief that their LDL has to be exactly 2.0. If it goes to 2.1, that's the end of the world. So, yeah, that's definitely a big clinical problem.
Yeah, and especially, and now as well as I do, that now people get access to their labs, and they're now obsessed by them, and it's one of the reasons we're going to talk about cholesterol, and it's one of the things that so it is useful to get repeat measurements sometimes, but they can be very misleading. I mean, if we don't really understand them, I don't know how we can possibly expect patients to get this, and it's really, we need to train them, once you guys know this concept, to say, when you see that you're, let's say an LDL cholesterol is 2 and it's not 1.9. You don't need to lose your mind over it. So let's talk about cholesterol. So cholesterol is a good example of where we have to take into account that variation. And so the analytic and biologic variation, and we'll talk about all of these numbers at the end because we got some tables we're going to provide you guys. So LDL, HDL, cholesterol. When you combine the analytic and biologic variation, they're about somewhere between 10 to 20%. So when you get a single measurement, it's sort of plus minus 10 to 20%, which is actually way more than I thought it was. I'm sure you didn't think it was that much. Yeah.
No, that's pretty wide.
Yeah, and it's not the fault. It's primarily the biologic problem again. And so a number of people have talked about this. A colleague who I've spent some time with, Paul Glasziou, in Australia, they've mentioned this, the variation, they published this years and years ago. saying that the sort of a 15% variation. And here's what I think is useful to know. If you know the variation, and you know that on average, an increase in cholesterol is, as you get older, and in fact, some data suggests that cholesterol does not go up as you get older. But even if it was increasing, it is only going to increase about 0.5 to 1% a year. So if you have analytic and biologic variation of 11 to 20%, there's absolutely no reason to measure cholesterols every year, because you'll see so much more variation than you will in actual change. So it's why some guidelines and people are suggesting you only measure it every 3 to 5 years. And just the most recent guideline I think that came out said you measure it every 10 years. And it's primarily for that reason. But I know people get these measured, yearly and sometimes even more frequently. I'm sure you've seen that, Jessica.
Yeah, and it's funny because most of the trials, I mean, many of them measure at different time points. The trial is, you're on the statin, you're on that set dose for the trial. So when we're looking at all-cause mortality or various morbidities, the drugs are not being titrated according necessarily, depending on the trials. And so I think there's a danger. You measure too often, then you want to do something about the change that you think you're seeing. And you might deprive someone of being able to avoid drugs, or not be, they should be just continue on the drug that they're on. And there's also a great burden, right? Just doing people's tests all the time, the stress, the time off work, when they used to think they had to fast for these tests.
Yeah, exactly. Yeah, no, so really good points. And I think now some of you are going, well, if there's such variation, how can we even study these agents? Well, the cool thing about it is, like if you were to do a study of 1,000 people, or even actually 100 people, to see what effect does a statin have on cholesterol, when you do study hundreds of people, and you do numerous measurements, that whole problem with biologic variation goes away, because you're doing multiple measurements in multiple people. So we can confidently say that statins reduce cholesterol by this amount. What we're talking about is, can you then do it on that patient in front of you? Because here's just an example. This is, by the way, this is not to suggest that we should be targeting LDL levels, because I don't think we should be. Again, a huge debate. I can go on with that. But here's just a really interesting example. If you were to give 10 milligrams of any statin de jour, whichever one you want, you get these ballpark changes in LDL cholesterol. If you double the dose, I'm sure you can notice that you don't double the effect. And when you quadruple it, and when you octuple it, you don't get that much more of an increase in LDL cholesterol. So you get most of the reduction in LDL cholesterol from that first dose. And in fact, there's data with 5 milligrams and even less. I know with ezetimibe, you get half the effect with a 40th of the dose. So it comes as 10 milligrams. If you take a 40th that dose, you still get half the effect. So we are really seeing that you get 100% of the effect if you get 100% of the effect from 80 milligrams, if you cut the dose in half, you lose 5% of the effect. If you cut it in half again, you lose 85% of the effect. And if you cut it in half again, you lose another 25%. So even if you go from 80 down to 10, you only lose 25% of the actual effect.
And so you won't even be able to tell in that individual patient, right? How if you slightly adjust the dose, the RCD
no, exactly.
wipe that out.
And so that's exactly the problem. It's one of the many problems of targeting cholesterol levels because of this variation, it almost proves the point that targeting different LDL levels is useless, because we can't be that accurate about it. Because here's an example: when you let's say you got a person and you measure their cholesterol and it comes back at 4, there's a variation around that. So let's say you give a statin and it reduces. Let's say you give 10 to 20 milligrams and you reduce it by, that reduces cholesterol by about 1/3. It's going to come down to there. Now you can probably pick that up, but there's still a lot of plus minus around that. So, but if you did, a few measurements, you might be able to see that it actually has come down. But certainly what you can never tell is when you then go to higher doses and try to get to targets, you only see another maybe 10% gain by, really increasing the dose. You literally cannot pick that up with the problems of the analytic variation. Now, sometimes you will. Sometimes the number will come down. You go, oh, good, aren't I brilliant? It worked. I gave, but you're really just seeing the natural variation. So if you ever see the benefit, just as I said, never measure again. So, and that's why, I said, a number of people saying you don't need to remeasure cholesterol for at least 8 to 10 years, especially if they're not on treatment. And then again, what we'd encourage you guys to do is, if you have a ballpark cholesterol number, put those ballpark numbers into this calculator, and you can calculate ballpark risks of cardiovascular disease using all sorts of different types of calculators. And you can use this to show the benefits and potential harms of the treatment. And I think a very useful tool, so that we don't get obsessed with getting people to targets, but we talk about their risks and so on. So potassium. So this is the last case that we got, and I'm going to let Jessica go through that.
Sure. This is, I mean, I see this all the time, admitting people in the hospital or whatever it might be. And so this was a not so long ago case. A fellow came in with chest pain. The attempt was made to rule out cardiac causes, with troponins, EKGs, and so on. And everything else was reassuring. But of course, as part of the panel, they ordered the electrolytes. And the initial measurement was 3.5 millimoles per liter. And then he was held in the department for follow-up troponins over a couple of hours. And again, electrolytes were drawn, and now the potassium looked lower at 3.0. So when thinking of variation, I wondered, okay, well, it's dropped. You know, the nurse called me to say, would you like to supplement the potassium because it's dropped? I need to make a decision there, and I have to think: is this change real? Is it problematic? You know, and what if the nurse had called me as 3.1 instead of 3.5? Would I be as worried? Should I be? So I think James has got some screenshots of us. We punched this into the calculator that's available through that BMJ link. So you basically, how it works is at the top you choose the test that you want to look at, and then you can put in the lab results that you got. So in this case, one of the results, it doesn't matter which order you put them in necessarily, but 3.5 and 3.0. And then you can click and it's going to show you the RCV there. So the range where the actual true number is thought to fall, and it can help you tell if one value is outside. So I think the next screenshot has it.
Yeah, and I just thought I'd add, so what this sort of shows is that, so the line there, the 3.1, that sort of shows the sort of variation that you're seeing. And what we also don't need to get obsessed by is this is not black and white either, right? It's just suggesting that if you're looking at RCVs, if this number, the 3, is outside this range, then we are comfortable saying that it's likely changed. Doesn't mean it's changed from 3.5 to 3. We just know it's gone down. Whereas if it was 3.1, oops. So there's the 3.5. Now, if it was 3.1, go ahead. You can see that it's just right on the edge of that.
Exactly, that second result's within that range. So you can't tell that there's actually been a change. And this matters, of course, with either scenario. You can't, potassium is a great example, because normally you could calculate how many milliequivalents of potassium you might supplement a person to make up that difference. I don't think that math actually works, but that's sometimes how we're taught.
But what I can tell you is that 1 slow K a day is useless. Period.
But in this case, I can say, okay, yeah, it's definitely, something is different, or something might be different, but it also might not be.
Yeah.
And in the case of where something is different, I might think, okay, that's outside of the RCV. That's a real change. I would probably think, why is that happening? Is there something clinical that's going on? Did this guy get a bunch of IV fluids? Was that a good idea? Is he just diluted? Is this just his individual that seems like a lot of variation over a 2-hour span. So that maybe there's something else going on there. But in the case where it's 3.5 to 3.1, I might say, there's no way for me to tell. I'm not going to worry too much about it. If that number was lower, that's up to my clinical judgment. If it was 2.1 coming down from 2.5, that would tell me I probably wasn't supplementing enough potassium, but I can't say that for sure.
Yeah.
Technically speaking, right? But I would still be worried that it was low. So I would just continue doing what I was doing, or be more aggressive, or choose to monitor more closely. So you can see how, like, when you just look at the top part of the screen, the numbers 3.5 to 3 or 3.5 to 3.1, it's pretty much the same question, same, it's not a big difference in those two scenarios. But when you look at the certainty of knowing there's a difference, that's where it kind of starts to fall apart. And but hopefully this doesn't scare you, but it makes it easier to accept that some things you just won't be able to know.
Yeah. And I think what's important with this is you don't do this if you did this every day, you'd never get through your practice. You see patients, but once you've done it a few times, you get an appreciation for how much variation, how much does it need to change, so you can be comfortable with the change. And once you know that for the top 20 or 30 lab tests that you're doing, it actually has a big impact on your decision-making process.
Yeah, and you mentioned at the beginning how patients are getting their own results. So when they come into the office and they say, "Oh, like my MCV was 98 and now it's 99," or whatever
Yeah,
a
whatever
number,
numbers. Yeah, yeah.
and they're worried about it because it's flagged just slightly outside their reference range. I find it empowering to be able to say, yeah, there is a change according to the lab. Let me tell you how that works. If it's something we're truly worried about, we could repeat the test down the road if it's something that's trending the wrong way. But usually just an explanation of some variability and that particular number doesn't mean anything. And what's more important is, their hemoglobin or whatever else. That's usually helpful. But if I couldn't tell them about the variation, they would still be looking at me for an explanation. So maybe it could be used in that way.
Yeah, exactly. So now what do we do? So we've given you some ideas of what to do. Jessica's done a great job of that. But I think the bottom line is, I think we need to embrace our nudity. I think we need to stop giving the perception that we're very precise, even by using, multiple, like your cholesterol is 2.1.37, ridiculous examples of going to decimal points and so on. So this is not a fixable problem. The lab has fixed the problem. They fixed the analytic part. They fixed most of the, lab errors and stuff. So this is only a knowable thing. And so that's why we're doing this session with you guys. So I would encourage you to go check this article out. I know someone on the chat said, well, they don't have an access to the BMJ. So it is tricky, might be tricky getting the article, but we've got enough screenshots of it that you can get most of the data that you need anyway. And that calculator is free. You can just go there and use it on the site. And we've already sort of given you an example, but I'd suggest that you go look at some of the lab values that you routinely do, throw a few numbers in, and you'll quickly figure out how big a change. Like this is just the example of how big a change do you need to see with an A1C to be comfortable that it's out, that we now are ruling out that it's a problem of analytic and biologic variation. And in the paper, again, I don't expect you guys to read this on your screen at this very moment, but in the paper, we give sort of 3 columns for the top, whatever that is, 30 or 40 lab tests that you see. And so there's 3 columns. The first one is sort of the confidence interval around a single measurement. So if you've just done one measurement, that's sort of the analytic variation, because clearly if it's just a single measurement, there's really no biologic variation. There is biologic variation, so it's a bit confusing, but it's not a biologic variation that you need to take into account. So there's that one column on the left is sort of the analytic variation. Then you can incorporate biologic variation. So that's something that you might want to consider around if you're going to be doing more than just a single measurement, that you might be doing repeat measurements, so that's now the analytic and the biologic variation together. And then the thing that's highlighted there in the red is the RCV, if you will, or how big a change you need to see for a measurement to be considered different. And I think it's really important that you look at some of these tests, like look at vitamin D. Vitamin D has to change 30 to 40% before you can be comfortable it's changed, which is why in BC, they stopped paying for vitamin D levels because they were, way too many were being used. And you can't interpret them, because if you give 1,000 milligrams of vitamin D, it doesn't change your vitamin D enough to get outside that variation. And I think some of the ones that are really quite interesting are, like chloride, osmolality, sodium, those sort of electrolyte things are pretty there's not much biologic variation because our body handles it very well. But when you get up into A1Cs and the different enzyme tests, HDL, and if you look at triglycerides, if you look at iron, there's a lot of plus minus there. I think you'd agree, Jessica?
Yeah, I was a little surprised to see bone density up there because as more precise, because I remember one of your podcasts I looked at some of the variation there, but the others were kind of in keeping with what I experienced clinically. Like people used to titrate drugs for uric acid for gout, which turned out to be totally useless. And now I'm wondering how much of that was because of that variation.
Yeah.
There's a lot that just, we kind of say, oh, magnesium, it's a little bit off, like we'll check it again in a few days. And I think there's some we're more comfortable just waiting or not being too worried about that minor variation. But there's other things that we're still very fixated on. I don't think CRP is on here, but no. That would be fascinating.
Yeah, but so just to point out the bone density. So actually the bone density test is you get a very close measurement of what actual bone density is. But here's the difference is, but when you give a drug, it only changes bone density by maybe 1 or 2%. So,
still under
that it's still under that. Yeah. So whereas, cholesterol is, plus, depends on what number you look at. It's, 10 to 20%, but you can change cholesterol by 30% with a drug. So that's the nuance of, you can have an extremely good test, but if your treatment doesn't change things much, that's another thing that you need to take into account. So this is sort of just an image that we created actually just for the first slide, but it puts all of the tests that were in that thing into this sort of dartboard, if you will, and you can have just a quick look to see where does chloride and sodium fall and HDL, and it just gives you a ballpark idea of how much variation you need to think about. And so this is just making the slides even bigger so you can actually get the numbers. I don't think there's anything we need to talk about, but those are some of the numbers that are associated with it. And I would encourage you over the next week or two in your practice, have a look at this when you're doing a lab value, just to have this chart by you and have a quick look at it and go, I need to know this when I'm making decisions about that. So if I was the boss of lab result reporting, and it was a fascinating, it was fascinating presenting to the lab people when I did this talk a few years ago, and they all went, yeah, we know this. And I go, yeah, but why aren't you telling anyone? Why are you not helping people out? And there were so many reasons given. Well, we can't put anything in variation because it'll confuse healthcare providers, or we can't put color in it because it's being faxed and it's black and white. There were so many reasons. And I think it's if you're waiting for the lab to help you with this, they are very good at this. If you actually phone them up and ask them, they will mention, they know this stuff, but you need to be aware of it. And hopefully with some of the numbers we've given you there. So I think it would be great if I was the lab results would always provide the imprecision. I don't think that's going to happen in the near future. I think they can maybe even provide much more definitive guidance as to what you do with those things. We need to really stop using terms like low, medium, high, or significant, because those are they're very arbitrary terms, and they don't. If I tell you something is high, my definition of high may be very different. And then if we're getting risk factor measurements, then we should be using those only to provide risk estimates, not necessarily getting these thresholds. And then this is another talk, Aaron, if you wanted to invite us back again, I'm sure Jessica would help us as well. So this is there's a whole concept around pre-test and post-test probability that comes into this entire discussion that is really, really important. And I think, maybe we should make more tests inconvenient to get. I'm sure that's not a popular thing to do, but you should just not be allowed to measure cholesterol every day, and those sorts of things. So some really key things to think just about the end, and I think we're just about at the end. Obviously, we have a lab values, but these are all the other things that you need to think about. And I'm not telling probably any of you that anything new, but have you looked at how the patient is clinically doing? I remember as a young baby pharmacists in St. Paul's Hospital, we would focus on aminoglycoside levels and forget that we needed to look at how the patient was doing. And it was crazy, because aminoglycoside levels, again, another topic all in of itself, are really the thresholds or the targets that we try to go are not based on much evidence at all. And then you need to know, if you're going to do a test, will it change what you would do? Because if it's not going to change what you do, then don't do the test. Does a risk factor test improve your assessment of risk? I'm sure for those of you who've been in practice for a number of years, probably I'm trying to think, Jessica, how long ago is it the guidelines used to recommend doing CRP, high sensitivity CRP for people, for cardiovascular risk assessment?
Oh, well, at least 5, maybe 10 years ago.
Yeah, but it was pushed and pushed and pushed, and why we don't do it? We should never have done it in the first place.
Terrible idea.
And one of the biggest reasons is because of the biologic variation of it. And it's not a very good predictor. And then if you're going to do a repeat test, how big a change are you expecting from your treatment? So with the cholesterol one, if you can only expect a 10% change in cholesterol, you shouldn't redo it. And then the sensitivity and specificity of the test is something you've got to take into account. How long does that change take? Because, it may, depends on, if you give a treatment, it may be bone density may take, for instance, months to change, whereas maybe you can change potassium much quicker. And then back to the whole concept of how big a change is needed to be confident that a change has occurred is really important. And hopefully we've given you some useful information on that. And I'm happy to take any questions. I'm not going to even mention, well, I'm going to mention Tom Perry's comment. He said he was diagnosed recently with being pre-dead, but apparently I was also postnatals. Yeah. So we're all pre everything. It always reminds me of our good friend and colleague, Bob Rangner, who said, high blood pressure is better than no blood pressure at all.
Yeah. I think as Erin's gathering some of the questions for us, I just want to add on that, the slide before, and I know there started to be some questions about things like COVID and so on. I think a lot of this way of thinking, it's very powerful. So even if you don't familiarize yourself with reference change values for specific labs, I don't think that matters. But all of those questions about putting the test in the context of the patient and what does it mean, I think it applies to cancer screening and how we use the PSA, for example.
Yeah, exactly. Yeah.
And we learned, okay, well, maybe it is a useful test for where we've taken someone's prostate out and we want to see if any of that tissue is regrowing, and like, is there some PSA or isn't there? But each test has to be used in a clinical context that's sensible with how the test works and that amount of variation that's there. So hopefully I think some of the questions are along those lines. Erin, you've got quite a few there, I think.
Yeah, I do. And one first thing, thanks Jessica and James, an excellent talk, very insightful. Maybe I'll give you a chance to grab a sip of water while I just remind people, enter your questions in the chat, make sure you fill out the evaluation. Even if you don't want the CE certificate, we really would like to hear from you and ways to improve or things that you liked or didn't like. Getting a lot of thank yous in the chat. And maybe let's start with the questions. At least first a comment from someone. I always teach my pharmacy students, treat the patient, not necessarily the lab, which I think you've echoed in your presentation.
Yeah.
Let me get
it's difficult though. It's difficult though, because patients are vague, but numbers are specific. And we lose that thing, but I think it's such an important concept.
Sure. Good point. Someone's asking about the COVID tests and the RCV. Another person said their patient had 4 COVID tests back to back, 2 are negative, 2 are positive.
Yeah.
So what's going on with that?
Part of that. Just for me, because I was running briefly the COVID assessment here and kind of optimizing swabs. And I mean, there is a huge place. It's not I won't speak to the RT-PCR portion, but just the sample collecting, highly variable from clinician to clinician, how the sample is taken. I think that the actual lab, the analytical error there will be much wider than with many of our other tests, because it's something that most people are not familiar with. It's an uncomfortable test to administer. And there are some competing factors there. So just that some of the variability in COVID you'll see is from just where the sample is taken, how it's answered, the other half of that.
Yeah, and it's a great question, because interestingly, none of this has anything to do with tests like a COVID test. Because with a COVID test, it's either positive or negative. It's not, it's not a certain number that's associated with it. So, and we've done a lot of work with the peer group and our tools for practice and stuff on this. So the way to think about that is, so with a PCR test, where you're trying to figure out, does the person have COVID? Not serology, but are we doing it with either with a swab or whatever? The nice thing about that test is it really doesn't have anything to do with lab. There's no biologic variation. You don't have varying degrees of COVID. I mean, you do have various effect, but you either have it or you don't. And so the way to think about that test is all about sensitivity and specificity. It is an exceedingly specific test. If you test positive, almost for sure you have it. Where the problem is the sensitivity is that if you test negative, and that there's varying degrees of sensitivity, it may be there may be a 20%, 10% false negatives, and that's to do for a variety of reasons. And one of the most important one is how well we do the sampling.
Okay, thank you, James.
Yeah.
And Jessica. Someone's asking about repeat testing and regression to the mean.
Yeah, so regression to the mean is kind of part of that biologic variation, and regression to the mean is the way I like to think about it is a person will come into you when they're really sick. So the nice thing about it is, or with their height of their frustration with their illness, and likely the only way it could go is to get better. So no matter what you do, they will get somewhat better. and I'm obviously making some generalization, but regression to the mean is kind of simply that, is that when you identify something's outside that range, but it's not really to do with lab, it's somewhat to do with lab tests, but really regression to the mean, the way I think about it, I'd be thinking that's the sort of biologic variation, but but regression to the mean is a different concept. I don't know if you want to add anything to that, Jessica, but regression to the mean means, if it's high, it's likely going to be lower the next time. And if it's low, it's going to be higher the next time. And that's somewhat to do with biologic variation, I believe, but that's another nuance of medicine that, when a person comes in, when they're sick or their pain is at a certain level, almost no matter what you do, it'll be lower because we have a tendency to get better.
Okay, thank you. I'm seeing a quote from William Osler: "Medicine is a science of uncertainty and an art of probability." So
exactly.
Yeah. Does RCV vary with age, which may be?
Yeah. So the RCV does vary. We can't be precise about RCV. That's the problem. That's why we put those ranges, 10 to 20%, or 6 to 10% or whatever, because we can't be precise. And I'm unaware. It's hard enough to get the biologic variation in people in general and be that accurate for it. So I'm unaware of studies that have shown whether as you get older, the biologic variation is greater. I just don't know, but I don't think it really matters, because we've given you, for the RCV, we've given you such ranges that I'm sure most people will fall somewhere within that range. And I certainly wouldn't be saying specifically for people who are, plus 80 or whatever, that you would deal with that any differently. I think the numbers would be close enough that you can use them for making decisions. Now, there's a whole bunch of other issues around what do those lab tests mean in people who are older, but that's a whole other discussion.
Yeah,
Sure.
we don't even have the reference ranges established for most things. Like look at chronic kidney disease. Well, any of my 90-year-old patients by definition has chronic kidney disease, but nobody has a GFR over 60 when they're 100
Right.
years old. So, but we just haven't really looked at what would be normal in that population range. So there's that, and I'm sure there's variation across gender in reference change values for specific things, and maybe even ethnicity depending on genetic complements. So, but I agree with the point. I suppose it doesn't matter. You just have to know that there's gray.
Yeah, and your example of even measuring renal function and albumin and proteinuria, my goodness, there's a lot of those tests are just plus minus, like I'm completely exaggerating, but they are close to plus minus infinity. There's a lot of variation. And if you guys are into that, that's a really interesting discussion about the whole problem of chronic kidney disease. I mean, it's most of it's lab test based, and boy, is there an issue with lab tests when it comes to that condition.
Maybe another webinar
Yeah.
for the two of you. Okay, I'm very interested in your comments on this one. It relates to other stuff people like your group and the TI does, but what are the legal implications of using this kind of tool for decision making?
Well, legal implications are always tricky. We get the same question all the time when we say, guidelines. People say, if I don't follow the guideline, am I going to get sued? And the answer is, from every lawyer I've ever spoken to, the answer is not. That is not what happens. The best advice I can give you, we can never reduce our legal risk in medicine to zero, and there's no RCTs of this. But commentary from the lawyers who look into this, the best way to reduce your risk of legal issues, you can't reduce them to zero, is use tools like what I've suggested, like doing risk calculators and have discussions with patients about the benefits and harms, and do those risk tools and so on. That reduces your risk by the greatest amount. Just following guidelines and making sure you follow it does not reduce your risk as much as doing shared decision making and engaging in that discussion, and also documenting those decisions. Those are all the things that I've been told that reduce your risk. But you can get sued, as unfortunately many people know, for a lot of things.
Right. Well, the CMPA, because I work with Choosing Wisely and so on, and the CMPA have done some talks with the Therapeutics Initiative in the past about this. You know, when the TI says the best available evidence is X, but the BC guideline says Y, you know, what do you do? And really, it's all about what's appropriate for the patient in front of you. And if you have that discussion of, you know, we discussed this and the conflict in these recommendations, with respect to this tool, that lab variation, I don't know how you would document that per se, but what I would write in my note for the potassium patient, I might say potassium has declined marginally, maybe normal variation or something like that. And I might discuss that with the patient. I say, if you're the kind of person who wants every number buffed and, you know, I can give you some potassium, but the risk of that is you got to take a pill for a few days. You probably have to have another blood test, make sure we're not overdoing it, blah, blah, blah. You have to go to the pharmacy, which is a bit of a hassle. I think it would be fine to not do anything. Because I think we cause this in the hospital by giving you fluids, or because this variation is so small that I can't even, I think it's just lab error, and I can't be sure one way or the other, but it's not dangerous. And so, I mean, it's up, you can have those type of discussions. But yeah, it's really, I think if you involve the patient in the decision making, or you make a clear recommendation of like, you know, this actually won't affect this LDL being a little bit higher. I don't know if that's real. It's not going to affect your health because the studies are on people who take statins for 5 years. They don't change the dose, and that's where the benefit is. So please carry on with what we discussed before when we started the statin. But it's a lot easier if you just don't order the test. Was that you can't find a fever if you don't take a temperature from. And it is a case for judicious practice. Yeah.
Yeah, and the other line is if you're not sick, you just haven't had enough tests.
True. So along that line, one of our friends, Jen, just said that the CMPA and Choosing Wisely had a webinar on this recently or last week, and it was recorded and posted on the Choosing Wisely website. So check that out. And I remember the CMPA person that spoke for the TI, Jessica, referred to the documentation part as leave your intellectual footprint in the chart. So that phrase stuck with me as something that might be useful for clinicians. And, you know, if you're using the tool that's developed for lab uncertainty, you can almost prepare a standard few words for documentation that you could use and then add the patient specific details so that you're not having to redo all of the documentation over and over again. We have 14 minutes left or so. I wanted to get to some of the other questions. Here's one. I wonder if INR or PTT have been reviewed. These are measurements directly linked to medication management on an ongoing basis.
Yeah, that's a great question. I off the top of my head, I don't have those numbers. And I've learned in my career very quickly to say if I don't have the exact numbers, I shouldn't talk about it. Because it gets, yeah. So I actually don't know those. I mean, now those are also very important to think about. Those are all, again, risk-based things to some, different. That risk is really when we talk about whether you should use warfarin and so on. So yeah, off the top of my head, I don't know. I'd have to go look at those. I don't know. Sorry.
Okay. Mark, friend of ours, isn't the specific variation less important than the fact that there is variation?
Yeah, absolutely. I think, and good to, thanks for being on the thing, Mark. You need to know that there is variation, but I would say, I think you do need to know somewhat the specific variation because, you know, there's a big difference between potassium and cholesterol or whatever. So you're right. I don't think you need to be precise about the variation, but you need to know that there's some subtle differences between, you know, potassium and say vitamin D and those sorts of things. But yeah, I think it's really, you need to be aware of a ballpark variation. And it's, you know, medicine is all about ballparking. When people ask me, well, how effective are statins or how effective is this? Well, I don't, anyone who gives a number like it's 1.3% is just not making it up, but you can't be that accurate. So it's always about, well, it's about maybe a 1 or 2% absolute benefit, or it's about a 10% absolute benefit, or it's about whatever. And I think, you know, we try to be accurate in medicine, but we need to realize that we can't be, because we're unfortunately dealing with humans, and I mean this in the nicest of ways, we're all genetic mongrels. And again, that's a Bob Rangno line. So you don't get on my case if you took offense to that, but we are genetic mongrels, and we all respond to different doses, and we all respond to everything. So I think if we And I don't know about Jessica, about your experience, but it has been my experience in talking to people. They are okay with this variation. You know, there's a few that don't like, but they are okay if they realize we can't know everything.
Yeah, it can be
Oh,
uncomfortable.
sorry,
But
Jessica.
it's just part of everything we do
Mm-hmm.
every day. I mean, the more we learn, the less we know.
Mm-hmm.
And I find in some respects, I'm not a clinician anymore, but just hearing about this, if you look at it from a different perspective, it is liberating to know that we don't need to panic about change, or we don't need to, I'm happy doing nothing most of my life. So if something changes and I don't have to do anything, I'm happy with that. So
Yeah.
Maybe it's about perspective. Another question for you about potassium. When it takes time to be tested, hyperkalemia is very common. Is it analytical variation or error from the lab?
I'm not quite sure what the question means.
Technically, that would be, it's kind of in between. So there was some other comments.
There's processing error. That in my mind is lab error.
Yeah,
Okay.
theoretically,
but it's irrelevant what it's called. It's not. But neither of those. I wouldn't consider that sort of analytic error or biologic error. That's sort of the lab error in that, you know, the sample has not been, and maybe it's stored properly by the time you're getting it measured and so on, or it's being stored too long or something like that. So that's different.
Okay. I was just told that maybe our ad said the session ends at 1, so we're already over time.
Yeah.
Maybe I'll wrap it up. Once again, Jessica and James, thank you. An excellent presentation, as I expected. Thank you for the attendees for signing in. We really appreciate the big numbers in the middle of a work day. Your comments and questions were excellent. As I'll just remind you that the video will be posted on our website within days. Complete your evaluations. You'll get your CE certificates. Sign into the TI website to be alerted to all our other educational offerings, and hope all of you stay safe and have a wonderful rest of your day wherever you are. And we'll be signing off.
Yeah,
Take care, everyone.
Thanks for your work on that, Aaron, and Jessica. Really appreciate all your great insight onto this. It's a lot of fun doing it as a duo.
Yeah, I think it's something I struggle with all the time. So I appreciate being able to have a discussion about it. And I know there's lots of great questions in the chat that we won't get to.
And people can feel free to email me and all that sort of stuff. And happy to get questions, and please just let us know.